Ceylon or Ceylon's Pearl Harbor then ensued, launched from these Japanese aircraft carriers, and the defences on the Ceylon side, on the Allied side, were some artillery guns, and the airfield from which the Hawker Hurricanes flew was the golf course. And this is the street scene in Ceylon at the time, in Colombo, and you can just see me in my pram. I was 2 years old. This was Easter Sunday morning. I was being wheeled back from Easter morning service at the cathedral in Colombo when this particular bombing raid occurred. Of course, it rolled on to do terrible damage to the Allied fleet in several different harbours around Sri Lanka, but fortunately I was spared for another day, another visit. But I returned to Sri Lanka in 1978, prospecting for the site for a new Wellcome Trust Oxford University research unit, and I visited Colombo and Peradeniya and met some very famous people, as you can see. Professor Nimal Senanayake, who was just back from doing his membership in the United Kingdom. And I went up to Anuradhapura because my interest in those days, after working in Nigeria for 7 years, was very much focused on snakebite, the neglected problem of snakebite. And I should explain that the title of my talk, I'm going to briefly describe a collaboration between Oxford and Colombo in the area of clinical toxinology. Now, toxinology is that branch of toxicology which has to do with natural toxins. I'm going to be talking about snake venoms and plant poisons. So in my return visit, I was immediately very much impressed by the hold of traditional, particularly Ayurvedic medicine in the management of snakebite in Sri Lanka. And I was travelling with my oldest Sri Lankan friend, Mr. Anselm de Silva, the snake man of Sri Lanka, still, as he was then. And we visited this famous snakebite specialist hospital on the way up to Kandy. And one of the treatments they used was immersion in the oil bath. You see the bottom left there. And I was later very intrigued to find, and my dear friend Dr. Chris Uragoda, the great medical historian of Sri Lanka, was able to interpret this in near the famous Dagobah of King Dutagamanu, who was mentioned earlier this morning, by the way, an almost identical method of treatment being used perhaps 2 millennia earlier. So the position of traditional treatment for snakebite and other diseases in Sri Lanka was very well established, and it was something that had to be taken into account by a group that was endeavouring to test in a research manner some of the treatments, the allopathic treatments for snakebite. At this time, towards the late 80s, there had been an apparent rise in the incidence of snakebite and snakebite deaths in Sri Lanka. This may have been real or apparent. It may have been just apparent because of improved surveillance. It may have been already a movement of patients from preferring traditional treatment to coming to hospital. Well, one way or another, there was a recorded increase in the documented mortality. So probably about 800 people or so were dying of snakebite each year in Sri Lanka at that time. And I like to partly blame this epidemiological phenomenon, if it was one, on Mrs. Thatcher, our Prime Minister. Because you'll remember that she was partly responsible for the marvellous Mahaweli Ganga irrigation project. Some of you, the older members, will remember that project, which transformed the formerly rather arid dry zone around Anuradhapura, Polonnaruwa and so on, into a newly fertile area, attracting many farmers to the area. And of course, the basic ingredient for snakebite to happen is an interaction between people and snakes. If they keep apart, there wouldn't be any snakebite. That's quite obvious, but it's often overlooked actually. It's too elementary. So the ingress of many farmers into this newly fertile area was, I believe, one of the factors that perhaps may have increased the incidence of snakebite. So here is Mrs. Thatcher, and you'll recognise her husband, of course, and one or two rather famous latter-day Sri Lankan politicians and so on. And that was 1985, and a later manifestation of the same project, the Yan Oya Reservoir scheme in 2011. There was a general increase in the awareness of snakebite as a medical problem in Sri Lanka at that time. And I'm afraid this is too small for you to see, but there are actually some very famous names in this list of contributors to a special edition of the Ceylon Medical Journal. These people have become members of the newly formed Sri Lanka Medical Association Snakebite Committee. So there are people like Anselm de Silva, I mentioned him already, the snakebite, my dear friend Dennis Aloysius, a pioneer general practitioner in Sri Lanka, Malik Fernando, and Lakshman Rana Singh, I'll come back to him in a moment, and looking down the list, people like Wasta Silva and Rizvi Sharif. These names will crop up later. And I found later that I knew some of these characters at a much earlier phase of my life. You may not recognize me in the back row there on the left. In those days I had a very healthy growth of hair, please know. I haven't always been in my present parlous condition. And sitting in front of me was the young Lakshman Rana Singh, who went on to become a very distinguished paediatrician, a leading paediatrician in Sri Lanka. And in those days, he was my student. Well, of course, our roles were reversed later. I very much became his student. But this was back in 1967 at the Royal Postgraduate Medical School, Hammersmith Hospital. And a rather later stage, I think we're looking more mature there. On the right is Lakshman Rana Singh, in the middle is Dennis Aloysius, and on the left is a more recognizable version of me in my current senile condition. So our first snakebite project was launched in 1985. The timing was not very good because it was only a few months after the terrible Anuradhapura massacre, which some of you may heard about or even remembered at the time. We were strongly supported by Dennis Aloysius politically. He was a marvelous diplomatic person. He connected me with all the right people. And you can see our team, top left there, with Yamuna Galagidara, who was an excellent young Sri Lankan doctor who agreed to work with us. She had been with Chris Waragoda doing tuberculosis work. And David Theakston, a laboratory collaborator from Liverpool, and Rodney Phillips, second from the left, who is now Dean of the New South Wales Medical School in Sydney in Australia. So some of them have gone on to have very distinguished careers. We were based in Anuradhapura General Hospital, and right across the road from the General Hospital was this very large Ayurvedic hospital. And in those days, more patients, at the beginning of our work, more patients would choose Ayurveda rather than allopathic medicine. And Ayurveda is an interesting attitude to snakebite. This is one of the more controversial techniques called Nasna Karima. This is the treatment for crate bites. Now, crates, as you probably know, cause a descending paralysis, which ultimately affects the respiratory muscles, and the patient asphyxiates. Nasna Karima involves blowing an oily liquid, paraffin-like liquid, down the trachea into the lungs. So a common presenting feature of snakebite in those days would be aspiration pneumonia, which isn't in the textbooks as a cause of a result of snake venom. It was very much an effect of this rather controversial treatment. So I quickly learned, this project started in August 1985, I quickly learnt about the tragedy of snakebite in Sri Lanka, because the foot there is of a child brought in dead, only 2.5 hours after being bitten. And you'll see from the space between the two puncture marks made by the fangs, 28 millimeters apart, that this little child had been bitten by a very large Russell's viper. She was dead on arrival, and my colleague Nick Francis made this direct vertical section through the site of the bite, so you can see the track of the fang. Do you see that? Now, I'm afraid this is my only concession to the dentists in the audience. I do apologise. But I thought I'd show you a really marvellous fang. Now, for goodness sake, if humans had teeth like that, dentists would really excite. So there is a fang showing the way in which it angled through the skin, injecting deadly venom deep into the tissues subcutaneously. So this is the horror of snakebite lethality. It's not just an uncomfortable nuisance, it's a deadly disease. And a new feature which I'd never seen before from viper bite, this was Russell's viper-induced neurotoxicity, which is a special feature of the Russell's viper in Sri Lanka and parts of India. And the threat of acute kidney injury, this is in some of our patients in Anuradhapura ended up with Rizvi Sharif in the pioneering renal replacement therapy unit in Colombo. So this interesting phenomenon of a neurotoxic Russell's viper venom, in fact, if you read the old papers, and of course people don't these days, if it's pre-Medline, forget it. But there was an early description from Sri Lanka from 1910, a beautiful description, a fatal case of Russell's viper bite at Trincomalee. The eyelids had now a very heavy appearance, and the elevators of the lids exhibited paretic symptoms. A beautiful description of that. And here are some of the examples from the patients, our patients in Anuradhapura. Breakdown in skeletal muscle. So in managing snake bite, we have only one specific remedy, and that is antivenom, a specific antidote. And then, and still now, but as I shall tell you in a little while, the outlook is improving. Sri Lanka is dependent on imported Indian venom, antivenom, for the treatment of snake bite. That hasn't changed, but it may change very soon. And the attitude of physicians in Sri Lanka in those days was rather mixed. Some of them thought the antivenom was good, but others had become rather depressed and were quite sceptical. So we decided to test the antivenom formally against venoms of Sri Lankan snakes, because although Sri Lanka and India may appear to be quite close, I've already mentioned one feature of Russell's viper bite that suggests that the venoms may be divergent. So preclinical tests of the efficacy of antivenom are done in rodents, and we immediately showed that Indian antivenom was 7 times less effective against the venom of Sri Lankan Titpolonga, the Russell's viper of Sri Lanka, than it was against the venom that was used in its manufacture, the Indian Russell's viper venom. And that's not surprising, really, but it was a very striking difference. And what about clinical effectiveness? Well, we found that it was necessary to give between 5 and 20 vials of this Indian antivenom to restore blood coagulability. That's just one of the effects of pathological effects of Russell's viper venom in the human, is to cause coagulopathy, not just by destroying the coagulation factors, but also by inhibiting platelets and damaging a blood vessel wall and so on. Another thing, we were able, thanks to David Theakston's work supporting us from Liverpool, we were able to measure the concentration of venom, or more strictly venom antigens in the blood of the victim, and Hafkin Indian antivenom failed to completely eliminate the circulating venoms. I'll show you in a moment. And this was well recognized by Sri Lankan physicians, who seemed to have to take it as a matter of course. But Indian antivenom was extremely reactogenic. Sometimes you would enter the ward in Anuradhapura and there'd be a rattling sound, because several patients would be undergoing violent rigors, pyrogenic responses. This is due to pyrogens acquired during the manufacturing process. This is a basic fault of antivenom production. And anaphylaxis as well, and the only fatality I've ever seen any of my patients from an antivenom reaction was incurred during the study in Anuradhapura and under most unfortunate circumstances. And the antivenom had no effect against this special neurotoxicity for Sri Lankan Russell's viper. So this plot here is fibrinogen concentration with time along the horizontal, and the red lines mark the range of normal fibrinogen concentration, and you'll see that it took up to 12 hours or so to restore the calculable level of fibrinogen in the blood following this use of Indian antivenom. And this is the vertical axis here is the venom concentration. You'll see that even after several days there was still measurable venom in the circulating in these patients. So the antivenom had not fully neutralized the injected venom. Another learning curve for me was to become familiar with this classic syndrome of crate bites, and it's very familiar to anyone working in more rural areas of Sri Lanka. Patients are bitten, sometimes they don't even know that they've been bitten, while they're asleep on the ground in their homes, in rural homes. There may be no evidence of a bite, no local swelling that you would expect, say, from a viper or a cobra bite, but the thing that happens is this slowly descending paralysis, often with very severe abdominal pain, which is a classic symptom of crate bite in Sri Lanka and India. And these patients don't respond to anticholinesterases, and they don't apparently respond to antivenom either. And there's a striking patient there. This man had come and slept for the night guarding his rice crop in a little hut by the rice paddy field, and when he woke in the morning, oblivious of having been bitten, he found he couldn't open his eyes or open his mouth or speak. And the other picture there shows his eventual recovery from this transient but very worrying paralysis. And on the left there is another patient showing the very trivial marks made by the fangs of the crate, but with no local swelling. The cobra gave a rather different picture. Again, it could cause descending paralysis, but the local effects were often very severe. As you can see there, necrosis, tissue death caused by cobra venom, and massive swelling. So our conclusions from this first study we carried out in Anuradhapura was how common these bites were. There were some epidemiological features which were very useful clinically in distinguishing them, such as the nocturnal crate bites. Great disappointment with the effectiveness and safety of the only available antidote, and clearly a need for a new antivenom to be developed for Sri Lanka. And another case we saw which was emphasized the importance of a very under-recognized Sri Lankan snake at that stage, the hump-nosed pit viper. It's a very small, unobtrusive-looking animal, rarely more than about 10 to 15 inches long maximum, and yet it's actually the commonest cause of venomous snake bites in Sri Lanka. This particular patient was a 5-year-old boy who developed local swelling, but much more seriously incoagulable blood, thrombocytopenia, bleeding from the GI tract, and acute kidney injury. Indian antivenom was absolutely useless. This particular patient recovered after having peritoneal dialysis, and we did some studies with the help of an expert hematologist demonstrating the effects of the venom. So clearly hump-nosed pit viper, Hypnali venom, needed to be included in any future antivenom for Sri Lanka. The next development in this collaborative program on toxinology involved these two people in particular, Professor Rezvi Sharif, dear friend of mine, and as I've said before, one of Sri Lanka's pioneering nephrologists, who fortunately for me had developed a great interest in snakebite, because many of the patients with acute kidney injury you saw had been envenomed by Russell's vipers and sometimes hump-nosed pit viper. And she was then Arirani Ariaratnam. She's now married to a very distinguished lawyer, and she's now Nana Thasan, and she was the very loyal worker, clinical collaborator and worker in these studies that formed part of the Oxford-Colombo collaboration from 1995 onwards. So, as I mentioned, one of the main conclusions from the Anuradhapura study was we needed a new antivenom. We managed to find a British antivenom producer in Wales, and they were raising antivenoms in sheep. These are actually retired sheep. They're too old to produce wool any longer, and their mutton wouldn't have been edible, but they were able to produce very good antibodies. So these retired sheep, and there's a message there, I think, for some of the retired. there's useful life after death. And they agreed to develop this new antivenom called Pelongatab, which was a revolutionary sheep-produced FAB. That's a digested whole IgG. The conventional fragment is FAB2 with the FC fragment removed. This is just one arm of the remaining fragment. So it's a small molecule which has advantages for rapidly penetrating tissues. And they agreed to produce this, and the preclinical efficacy, the sort of test you can carry out in mice, was very encouraging. It suggested that the potency was 10 times greater than towards Russell's viper venom in Sri Lanka than was the Hafkin antivenom. And the clinical effectiveness, we then went back to Anuradhapura to test. And as it happened, our first patient in this study was a very, very dramatic one, who raised questions not just of clinical trials. This was a 12-year-old girl, and she arrived in our hospital only 30 minutes after the bite. Her main complaint when she was admitted was of abdominal pain, but as I'll show you, she was reckoned to be moribund, close to death, by our Sri Lankan staff. And there you see her foot. It may remind you of that earlier foot I showed you, with widely spaced fang marks, so a very large Russell's viper, by implication the possibility of a very large dose of venom injected. This little girl was barely rousable. She was neurotoxic. She had paralysis of the eyelids. She had unrecordable blood pressure. She was bleeding from her gums. She was vomiting blood. She was passing blood per rectum, and her blood was completely incoagulable. So here she is, see with these neurotoxic fasces, and a horrific sight, which I've very rarely seen anywhere in the world from snakebite, blood pouring from her anus. And there's the simple 20-minute whole blood clotting test. Her blood was completely incoagulable. So this little girl, I believe, was very close to death. So here's the ethical dilemma. What do we do? Do we use the government-supplied Hafkin antivenom, which there's a great deal of experience in Sri Lanka, but which we already know has very limited effectiveness? Do we use that, or do we use a completely new experimental antivenom that, all right, is very encouraging in animals? We decided to use the new antivenom, and we gave her a very large dose. She had an anaphylactic reaction, which is not surprising because these early reactions are dose-related. We were giving her a very large dose on account of her very severe clinical condition. However, it did seem to be very effective, because after only 2.5 hours, she stopped bleeding and her blood pressure came back, and after 6 hours her blood coagulability was restored. And there's the dramatic moment, 6 hours after giving this antivenom, when her blood, having been completely incoagulable, again clotted. That's very reassuring. It suggests that if there are breaches in her circulation, most worryingly it could be the brain or the gut, something like that, at least her hemostatic mechanisms were on their way to being restored. However, we weren't out of the wood yet. It seemed to be encouraging. She was still alive, but after 12 hours her urine output started to dwindle, and the urine was very dark, and she had persistent neuromyotoxicity, and then she had recurrence of her blood incoagulability. So we gave her more of this new experimental antivenom. There she is, by the way, at the time when she was clearly developing generalized rhabdomyolysis. Her urine is black coloured. And this, I think, for me, very dramatic graph, the solid line there with the dark circles is the venom concentration. So at time 0, she had a colossal venom concentration. The units won't mean anything to you, but nearly 400 nanograms of Russell's Viper venom per ml of blood. And you can see when the initial dose of antivenom, 6 grams, was given, the level of venom plummeted. So that's very satisfying. But then you see the level is creeping back again, because venom continued to be absorbed from the site of the bite, and at the same time the concentration of antivenom was declining. But eventually it was a good outcome. So after 36 hours, this little girl, her condition was greatly improved. Look at her face, absolutely transformed. She was passing clear urine. She had a painful swollen leg, the bitten leg, but this was the worrying thing. She was not moving her lower limbs. And as a follow-up, she shows slow improvement, but she had a residual spastic paraparesis. And my dear friend, one of Sri Lanka's most distinguished neurologists, Professor J.B. Peiris, reviewed her case and thought the most likely thing was that she'd suffered a spinal arterial thrombosis or hemorrhage during the acute phase of this very severe envenoming. So that was a very dramatic introduction of this new antivenom, and very difficult decisions. I won't spend long on the results. We did a preliminary dose-finding study which was quite encouraging, that the antivenom restored blood coagulability and it eliminated circulating venom, but there was an unacceptably high rate of reactions, and because of the small fragment size of the antivenom, there was a tendency towards recurrent envenoming. And in this picture, the solid line is the venom concentration. You'll see that it bounces back at each stage, and we had to give more antivenom. This is clearly a disadvantage of this antivenom. We then did a comparison between the new antivenom and Hafkin in a larger group of patients. And unfortunately, we chose too small a dose of the new antivenom. We compared 10 grams of Hafkin with 1 gram of the Pelongotab. And in this particular comparison, Hafkin, that higher dose, was more effective. So I think this was quite a bold attempt to produce the first ever specific antivenom against Sri Lankan venom, but unfortunately it failed. This is a real life experience. It failed. We had an unacceptably high rate of reactions, although it was lower than with Hafkin. And unfortunately the idea of the antivenom project was rejected at that stage. Certainly counter-incentives were offered by the Indian manufacturers, and the SLMA Snakebite Committee, I think probably quite rightly, decided to stick with Indian antivenom. The next study we did was a national survey carried out largely by Arirani Adiratnam at 10 hospitals throughout the country, comparing patients who had brought the snake as clear evidence of the species that had bitten them, And these data were used to construct a system of syndromic diagnosis management. So if the patients who didn't bring the snake, it was possible for the clinician to infer the identity of the biting snake through the pattern of clinical features. So you see there's a very large number of patients, 860 patients in whom the bite was absolutely proven, and see the large percentage of hump-nosed pit vipers bites, 35%. And I won't go into the details, but as a result of this study, we were able to produce this scheme for syndromic management of snakebite in Sri Lanka. Well, I'm glad to say that there is good news for antivenom in Sri Lanka, a later initiative coming out of our earlier failed attempts by this excellent group led by Indika Gavaramana at University of Peradeniya, and involving an excellent antivenom producer in Costa Rica. Now they're using only Sri Lankan venoms to raise this antivenom, and the preclinical testing that's been done, that's the rodent tests, have been extremely encouraging, and I'm told that a clinical trial is almost underway. So I think that the whole horizon for treating snakebite in Sri Lanka will be dramatically transformed in the near future. Now the final thing I want to mention is to do with suicide by poisoning, self-poisoning. And as you probably know, Sri Lanka has the rather dubious distinction of having the highest, or some of the highest, rates of successful suicide in the world. You see the peak there was in the 1990s of nearly 50 per 100,000 per year, compared to the world levels of probably half that. And that's on the right is a poster from Anuradhapura Hospital pointing out the circumstances leading to self-harm. And the picture bottom left will be very familiar to any of you who've worked in Sri Lanka, a very common problem of organophosphate poisoning, which is the commonest means of successful suicide in Sri Lanka. And I'm not going to talk about organophosphate poisoning today, although we went on, the Oxcol collaboration went on to do a lot of work on organophosphates, and I think has contributed now to a decline in suicide fatalities in Sri Lanka. Just one other mode of suicide, which is particularly horrible, attempted suicide, is self-immolation. These abused young women douse themselves with kerosene and set fire to themselves, and they're being marvelously looked after by a lady plastic surgeon in Colombo, University of Colombo. I'm sure many of you will know her. And these young women sometimes suffer 70–80% burns and are being very expertly treated. But the thing I just want to very briefly mention last of all is yellow oleander poisoning. And you can see from this picture how easily accessible yellow oleander is to anyone who has an inclination to kill themselves for whatever reason, or just as a demonstration. They only need to go into the garden and pick some kernels of yellow oleander. So this is Kaneru poisoning. This is the plant. This is the kernel, the black kernel, which gives it its Sinhala name. And the epidemic in Sri Lanka can be dated back to 1980. The plant is very abundant and it contains digoxin-like cardiac glycosides. It's estimated to cause 2,000 deaths a year back in when we started this study, with a case fatality of 4%. And the former treatment throughout Sri Lanka was gastric lavage, which you know is risky, very risky, and not recommended now. Single dose activated charcoal and large doses of atropine to try and overcome the bradycardia, and isoprenaline to speed up the heart, and then transfer to in those days, the rather few centres in Sri Lanka that could do cardiac pacing. This is just to show you how similar the oleander glycosides, thevetin and oleandrin, are to digoxin. And this gave us the idea that this structural similarity, that an available, a commercially produced antibody used for treating digoxin overdose, either called Digibind or Digitab, might be effective in these victims of yellow oleander poisoning in Sri Lanka. So a team at the National Hospital in Colombo, that's Senaka Rajapaksa on the left, who's now, I gather, very senior in the postgraduate medical body, Resvi Sharif in the background, and my colleague now in Edinburgh, Michael Edelston, who's been devoted to work in Sri Lanka for a number of years, carrying out this study. And that shows what dramatic effects there could be of the antibody. 2 patients there with bradyarrhythmias and heart block. In 8 hours, restoration of sinus rhythm. And this Kaplan-Meier plot shows the block dots, black ones are the Digitab treated patients, the white are the placebo treated patients. A very clear distinction, much more rapid restoration of normal rhythm, normal cardiac rhythm in the treated patients. Well, these are very clever monkeys, ladies and gentlemen. I don't know whether any of you've been to Zanzibar, but if you, next time you go, you should meet these monkeys. They have a very poisonous diet. They eat the leaves of Indian almond and other leaves that are extremely poisonous. But they've cleverly decided that the way to stop themselves being poisoned is to nibble this charcoal. They find burnt bits of wood where the forest has a very sound theoretical basis, and in Sri Lanka, an earlier study by my colleague Janaka De Silva and his team suggested that there could be a rapid reduction, a sizable reduction in case fatality of yellow oleander poisoning by using multiple rather than single dose charcoal. But a much larger study by our group, the Oxcol collaboration, disappointingly showed that this probably wasn't a real effect. That's the team that carried out the large study. So I'd just like to summarize now, and remembering the theme of this meeting, and in an attempt to express my gratitude to my colleagues in Sri Lanka who made possible this program. It didn't quite go back to 1942, but I think 1942 planted the seeds of my affection for the island and has encouraged me to return there and to find research collaborators there. So, first of all, I was extremely fortunate to find colleagues in Sri Lanka who were not only competent and committed, but extremely likable. You know, it's nice to work with people you like, and to make so many friends there, and also by our long-suffering colleagues at the hospital in Anuradhapura, where all this work was done. We also received very strong high-level ministerial support. These names perhaps won't mean anything to you now, but former Minister of Health, Dr. Ranjit Attapattu, was extremely helpful, and DGs of the medical service, particularly Dr. George Fernando. And the subsequent research on snakebite and yellow and poisoning in Sri Lanka, which has greatly improved the treatment of these two toxinological hazards, was really largely based and encouraged by the early work done in Anuradhapura back in that era. So I'd like to thank you very much for your attention, and again thank the organisers for the great honour of inviting me to give this oration. Thank you very much.